On behalf of Boulder Community Health, it's my pleasure to introduce this evening's speaker, Samuel Long. Dr. Long received his medical degree and then completed ophthalmology residency training at the University of Kansas Medical Center in Kansas City, Kansas. He specializes in cataract surgery, LASIK PRK, and other anterior ophthalmic procedures. He sees patients at Boulder Eye Surgeons with locations in Boulder and Erie. Welcome to Dr. Long.
All right, thanks for having me. My name's Sam Long. I'm a cataract and refractive surgeon at Boulder Eye Surgeons, and my talk is titled Latest Advancements in Cataract Surgery. All right, so I just wanted to spend a minute or so going over the basic ocular anatomy. So the eyeball is one of the smallest organs in the body, but also one of the most complex. There's a lot packed in there. At its most basic, though, it is a two-lens system. That means that light comes in the eye. It comes through the cornea, which is the surface of the eye. The cornea serves as the first lens. Light goes through the pupil, behind the iris, and then through your intraocular lens. That serves as the second lens in this two-lens system. This light ideally gets focused to a fine pinpoint on the central retina or macula. And so what is nearsightedness? What is farsightedness, or myopia or hyperopia? I think we all have an inkling of what these terms mean. We have minus prescriptions, we have plus prescriptions. Nearsightedness essentially is where one of those two lenses is too curved or too strong so that light focuses in front of the retina. With a pair of glasses, contact lenses, or cataract surgery, that light can be focused at the appropriate place. And vice versa with farsightedness, that's when the lens, one of the two lenses, is too weak or too flat. Light actually gets focused behind the retina, so it doesn't quite get into focus before hitting the retina and the photoreceptors that live there. What is astigmatism? This is a very common question. A lot of people know that they have astigmatism, but not everyone understands exactly what that means. So I think a good way to think of it is to use an analogy with food, as with most things. So the ideal eye without astigmatism is like the side of an orange, like in this photo, where it's perfectly round all the way around, same level of steepness, 360 degrees. And astigmatism is more akin to the side of an egg, where at 180 degrees away from each other, the same level of steepness exists, but 90 degrees away from that, it's a little bit more shallow, a little bit flatter, a little bit steeper. And so when this happens with astigmatism, that means that light hitting one side of the cornea may focus in front of the retina, and the other side, it may focus right at the retina. So astigmatism can really cause quite a bit of visual blur. What is accommodation? So I think a lot of people understand this one as well, maybe not the term though, in that once we reach our 40s, sometimes 50s, we lose the ability to focus up close, even if your distance correction is spot on. So in this photo, you can see this guy thinks his arms aren't quite long enough. He can't quite get that newspaper into focus. And the process of, or loss of accommodation is called presbyopia. That's what happens in your 40s or 50s, and that's what requires that bifocal lens, I think, that we all kind of know inherently. All right, and that is a normal aging process, by the way. Everyone goes through that at some point. All right, this is just an additional diagram looking at normal accommodation. And so you can see here, light's going through the cornea, through the intraocular lens, and getting focused to the retina, like we talked about before. When we're young, up until we're in our 40s and 50s, that lens inside the eye has the ability to change shape and compensate or change power so that we can focus both at distance and close up. And it's that process, that lens, that loses that ability to adapt or allow us to accommodate. And here's a diagram saying just that. Once again, loss of accommodation is called presbyopia. So if you hear that term, you now know what it means. All right, so what are cataracts? That is the topic of our conversation. So cataracts involve that intraocular lens. That's that second lens in the two-lens system that sits behind the iris or behind the pupil. What a cataract is when that natural lens essentially becomes cloudy and also loses the ability to change shape. The reason this happens is that proteins inside the lens, they cross-link, and then the lens loses its natural clarity. It's when what was once a clear window becomes more like frosted glass. That can cause all sorts of issues, whether it's just uncorrectable vision, even with glasses, or additional nighttime glare, halos around lights, starbursts around lights. I think a lot of people notice this, especially at night while driving from headlights. Here we go. So what do we do about cataracts? Fortunately, we have a very tried and true method or surgery to take care of those cataracts. Cataract surgery is the most common surgery done in the United States. It's very successful by many metrics. 95% of patients who have cataract surgery experience improved vision. So the basics of cataract surgery is when in the operating room, we remove the cataract from its surrounding capsule. There's a bag that holds that natural lens. We keep that capsule intact, and within that same capsule, we replace that natural lens or cataract with an artificial intraocular lens implant. There have been many advancements in cataract surgery throughout the years, throughout the last 50 years, really. Those include the incisions involved with surgery, the time of surgery, the efficiency of surgery, and hence the recovery of surgery as well as the various intraocular lens implants, which we'll touch on in just a moment. And certainly the safety of cataract surgery has come a long ways. Just 30 years ago, cataract surgery required an inpatient stay. It was a surgery that you had done and you had to stay overnight in the hospital. Now, it's about a 10-minute surgery in the operating room. It's a same-day surgery. And most patients recovered very, very quickly. The majority of the improvement in vision happens after one day. One of the newer advancements, and I say new, but it's been around more than a decade now, is laser assistance with cataract surgery. And as we'll talk about in a moment, laser assistance provides a lot of benefits to the surgeon and to the patient. And next up, we have a diagram. Maybe hard to make out the perspective that we're looking at here, but it's a cross-section through the cornea. And that's a cataract surgeon with his instrument through that incision, removing the cataract from the capsule that surrounds it. Cataract surgery of any type requires something called phacoemulsification. That involves the instrument that is inserted into the eye. It uses ultrasound energy to break up the cataract, and that same instrument then sucks out the bits of the cataract that it chops up. After that cataract is removed, a lens implant is placed within that same capsule. Whereas at one point in time, this required a very large incision, relatively large. Nowadays, we have these lenses folded up and inserted into the eye where they then unfold. You can think of this like a ship in a bottle. The incision size now for surgery is about 2 millimeters, so very small, and the entire lens fits through that incision. That type of incision heals very quickly. That's why it's important to us. All right, next up we have a video outlining laser-assisted cataract surgery.
With recent technology advancements in cataract surgery, surgeons now have options that allow patients to make informed decisions on how their cataracts will be removed. One such advancement has been the introduction of laser refractive cataract surgery with the LensX laser. The LensX laser is designed to bring a new level of accuracy and reproducibility to refractive cataract surgery. By automating some of the most challenging steps of cataract surgery, the LensX laser allows the surgeon to create precise, repeatable incisions using an image-guided laser. Cataract patients now have the following two options: standard cataract surgery or laser refractive cataract surgery.
Or laser-assisted cataract surgery. Thank you. The main benefits are reproducibility with the capsular rhexis like we talked about, but also because the laser is assisting us in breaking up the cataract, it requires less energy from that phacoemulsification, or the instruments we use inside the eyes, making it safer for the internal components of the eye, and then speeding up the recovery process because of that. I'm happy to answer any additional questions about laser-assisted cataract surgery after the lecture as well. And we can go ahead and stop it here. Thank you. All right, so who's a good candidate for laser-assisted cataract surgery? That depends on one's natural anatomy of the eye. If a patient can become well dilated for cataract surgery, that means more than a 5.5 millimeter pupil. If one seeks to correct their astigmatism or choose a premium lens option, which we'll talk about in a moment, laser assisted is needed really for these types of surgeries, these type of lens implants. And if one has potential for good vision, that means that there's really nothing else going wrong with the eye. There's no other pathology, ongoing pathology diagnosis, and nothing comes up on the preoperative exam. Those who are not good candidates are those with corneal scarring, those with poor dilation, as we mentioned, and those with some prior ocular surgeries like radial keratectomy or some glaucoma surgeries. So what are the risks with laser-assisted cataract surgery? That's always an important question when it comes to any type of surgery, and always worthy of a long conversation with your surgeon. So the risks actually with laser-assisted cataract surgery are the same as traditional cataract surgery. It does induce a little bit of bruising on the white of the eye, so the eye may not look quite as pretty for a few days after, but those effects are pretty minimal. The benefits, as we talked about, are reproducibility. That's a huge one. Case to case, the laser is very accurate. It uses image guidance in real time to create the incisions and do everything it does. As I mentioned, it's very precise, uses less energy, and assures us a stable lens position for that lens implant. So speaking of lenses, what are the options? We have really two main tiers here. We have the standard monofocal lens, which comes in a couple different brands. They're about the same. That gives you one standard focal distance. In a lot of cases, that gives good functional vision at distance, but still requires reading glasses. Then we have our premium intraocular lenses, and these are all used in conjunction with laser assistance. We have our toric intraocular lenses, our multifocal, accommodative, elongated or extended depth of focus lenses, and our newest technology, light adjustable lenses.
The traditional IOLs that have been used for several decades are called monofocal lens implants because they focus the light entering your eye at a single focal distance. This means that you will see best at either far, near, or intermediate distance when you aren't wearing glasses, depending upon the lens power selected by you and your eye surgeon. Most people who have cataract surgery with a traditional IOL choose to have a lens that provides good distance vision without glasses.
Understanding that you will need readers afterwards, reading glasses, that is. Next up, we have our toric lens implants. These correct astigmatism. They counteract the effects of any corneal astigmatism. They have a wide range of powers. The way we pick out our lens strength is based on measurements of the eye, and toric lenses will fit just about every eye, and they're best for those with astigmatism. Most of our lenses are made of an acrylic material, and really a material that will last 100 plus years. It'll last a lifetime.
Another way to correct astigmatism is with a toric IOL. Toric IOLs are
And once again, just a quick diagram. These are all about the same, regardless of the lens type that you have. Other than laser assistance, the surgeries all go about the same. We're removing the cataract and placing that lens implant within that capsule. Next up, we have our multifocal lens options. The first question I ask for patients who are interested in multifocal lenses is, do you hate glasses at any distance? Do you want to get out of glasses altogether, or for the most part at least? That's really who these lenses were made for. They can allow you to have the equivalent of what are trifocal glasses, albeit not the same. You don't have to look down to see closer like trifocal glasses, but they can give good distance, intermediate, and near vision. There can be some foggy parts of vision in the in-between zones. There are many positives to these lenses. They work great for a lot of patients. Some of the negatives, though, are that some patients experience a halo effect around lights. In most cases, that is temporary. It takes about a month or so to go away. And there can be some decreased contrast sensitivity with these lenses. That's important for those who are involved in certain professions like painting and so forth. So it's always worth having a good long conversation about the lens options, and the same can be said for the multifocal lens types.
multifocal lenses use specially designed circular.
And once again, you can see those different focal zones of the lens there, the different rings. This is just demonstrating that you have three plus distinct zones where your focus will be best at. Next up, there's really only one accommodative lens on the market. This lens seeks to somewhat replicate the ability of the eye to accommodate. And if you remember, what that means is even with good distance vision, you still have the ability to zoom in a little bit and see things that aren't quite so far away without glasses at maybe computer distance or faces just across the room. So they're primarily for distance and intermediate focal points. They do have a low incidence of halos, like you might see with the multifocal lens. They don't work as well in those with plus prescription or hyperopes. And they work well in the vast majority of patients, but some patients, while they do have good distance vision after cataract surgery with this lens implant, they don't quite get the effects of the accommodation. So no lens is perfect, but there are pros and cons with each type. This lens has a distinct look.
These IOLs have design features
that you would
that
never see it, but when we're inserting it in the eye, this is what we see. Those flanges on the end of the lens essentially, ideally, work with the natural muscles around the lens that your natural lens would have also worked with earlier in life. Next up, we have another lens that works well for distance and intermediate vision, while still requiring reading glasses for very near distance. It's called the extended depth of focus lens. It comes in a couple different varieties. They work about the same. And it can give, like I said, good distance, intermediate, about computer distance, but still requires reading glasses for things that are closer than that computer distance. And it doesn't come with the same downsides as multifocal lenses might come with. And our last lens type that we'll be talking about is the light adjustable lens. Fairly new in the United States, but this lens type was originally developed in Europe and used for over a decade there. It was brought to the United States about 6 years ago and FDA certified. It was actually first created in the United States as well, in California, and has had very good results. We'll talk about the mechanics behind the light adjustable lens, but it does have very good results. About 92% of patients are 20/25 or better without glasses. It's made of silicone instead of acrylic. That doesn't really cause any effect on the outcomes, but interesting all the same. And it's shown to have good lasting vision. It's a tried and true technology that's been tested for longer in Europe and a good amount of time here in the United States as well. All right, this is just a diagram that looks at the chemistry behind light adjustable lenses. So what is a light adjustable lens? It essentially is a lens, looks very similar to other lens types that's inserted into the eye during cataract surgery. And essentially we aim for the best possible vision the first time around, but we can make adjustments after surgery in our clinic so that if you're left with a small residual prescription, we can do a quick procedure. It's actually just a light being shined in the eyes, which makes adjustments to the prescription so that we can really hone in and get that vision spot on after the fact. And here we can see how that works. So in the clinic, UV light from the RX side machinery shined into the eye. This interacts with macromers, a collection of chemicals and proteins inside the lens. They interact with the UV light. They're photopolymerized, as we call it. All of this causes a change in shape of the lens, and that's how we accomplish changing the prescription even after surgery. So traditionally we use laser assistance for this light adjustable lens. One potential downside, but also a very important thing after light adjustable lens surgery, is that one has to wear specialized UV protecting sunglasses at all waking hours, unless you're asleep, until 24 hours after a final lock-in treatment. So how many of these adjustments in clinic are needed after cataract surgery with a light adjustable lens? Typically about 4 or 5. I think 5 is the average. And we typically do these at normal post-operative appointments. As you can see, the first treatment or first adjustment is made 17 days after surgery in our clinic. And every 3 to 4 days, an additional adjustment is made. There are a few things that would make one a good candidate for this type of lens. Once again, you must have good dilation. You must not be on any UV absorbing medications like hydrochlorothiazide, which is a blood pressure medication, or diuretic, and tetracyclines, which are either an acne medication or antibiotic. And who specifically is this type of lens good for? So traditionally, when we calculate the lens strength, regardless of lens type that you'll need in your eye, we are using really tried and true algorithms to come up with your lens strength. These are based on measurements of the eye. They've come a long ways in the last 40 years, really. And we do have good formulas that work in those who have had prior LASIK, PRK, refractive laser surgeries. But there's still some deviations. There's still some margin of error so that these patients still sometimes are left with a small prescription. In those patients, sometimes we do LASIK to fully correct vision, but that requires an extra procedure. So if we want to get it right the first time, and we're okay with a few adjustments after surgery, then really light adjustable lenses is probably the best option for post-refractive cataract patients. And as I mentioned, other technologies can give good outcomes, but no other lens type is really as accurate as light adjustable lens. I don't have any stake in the company that creates these lenses, but that's been my experience so far. All right, so there's no perfect fit for one and every person when it comes to lens types, light adjustable lenses included. So it's worthwhile having a good exam, a good conversation with your surgeon to help pick out the correct lens. Many of these lenses will work for a single person, but it depends on what your expectations are and what you want from surgery. And certainly light adjustable lenses can further address that. And we like to say patients can try on their prescription before we make adjustments with light adjustable lenses. That's very true. In fact, some patients with the light adjustable lens have one eye set for distance and one eye set for a little bit closer. That's called monovision. Doesn't work for everyone, but occasionally patients can try that out for a couple weeks. They don't like it. We can make an adjustment and revert that. And here we just have a summary slide looking at the various lens types and cataract surgery types. Standard cataract surgery with a standard monofocal lens in both eyes is really a great surgery to have done. It will correct your vision, it will improve your vision in almost all cases, but it often still requires glasses for your best vision at a chosen focal point, whether that's distance or near. And then sometimes patients require astigmatism correction. So for those patients, it's better to have astigmatism correction with laser assistance, which can correct some of the astigmatism by itself, or one of those toric lenses we talked about. Some of the best options we have, once again, laser assistance with either an extended depth of focus, a multifocal, or accommodating lens. All can be great options. Once again, just depends on what you want from surgery. And then we have our light adjustable lenses. One of the newer technologies in the United States, but it's been used for quite a while around the world, nearing in on 16, 17 years now. So it's definitely well tested. You wouldn't be a guinea pig if you were to get this lens type. And as I've been saying, there is no perfect lens. Cataract surgery has come a long way. Compared to a lot of other types of surgery, it is relatively safe with a low risk profile, albeit with risks. But there's no perfect lens. We have to find a lens that fits your lifestyle, fits your job, your hobbies, all of those things. There has been a rapid evolution of options when it comes to lens selection and cataract surgery. So the most important thing I can say is a patient really needs to speak with their surgeon. Ask as many questions as they can think of, talk to their friends and family who have had the surgery, come loaded with questions, and any good surgeon will spend any amount of time answering those questions and filling in the gaps. All right, that's all I got. I'm ready for questions.
Thank you very much
Thanks
for
for
the
having me.
lecture. Yeah, we appreciate that. We wanted to remind our audience at this time that now is the time for you to submit any questions that you have, and we will go through the questions and answer as many as we can. And these are in no particular order. This person recently heard cataract surgery can be redone, and they're wondering if that's accurate. They had surgery to get rid of halos. Somehow that didn't help, and they really want to drive again at night.
Sure. So in most cases, cataract surgery is intended to be a one-time deal. The cataract is removed from the eye. It's replaced with that lens implant. Sometimes multifocal lens doesn't work out, or a standard lens doesn't work out. Essentially, it's not fitting the needs of the patient and what they want to do throughout their days and nights. And so if you're not too far out from surgery, lens replacement surgery, essentially where that lens implant is removed and replaced with a new lens, is an option. It has a few more risks than the initial cataract surgery, and every case is a little bit different. That's the most important takeaway. So it's worthwhile to get a good, thorough exam if you're unhappy with that lens implant. So I'm assuming that's what you meant, is that this person, or what you had heard, is that this person had cataract surgery and then essentially wanted a lens replacement. If that's not it, I'm sorry. But the best advice I can give is to have a good, thorough exam and then go from there.
Okay. Thank you. So, post-surgery, what restrictions are there regarding exercise, weightlifting, etc., and for how long?
Great question. So that'll vary a little bit from surgeon to surgeon, but in my practice, I essentially have patients take about a week off from rigorous activities. You can still walk, even light jog, or go on a not very strenuous hike, but no lifting more than 10 pounds in either hand, doing your best not to get water in the eye. We have clear plastic shields we have you wear over the eyes at night so that you don't accidentally rub your eyes while you're asleep. But that's about it, and that's for about 1 week.
Okay. I'm going to try to pronounce this one. Which lens is best for someone like me dealing with a pterygium in my left eye?
Yeah, a pterygium. Yeah. So a pterygium is just essentially a bit of scar tissue on the surface of the eye that can sometimes get in the way of vision. So that pterygium, it depends on how extensive it is. Sometimes it can induce astigmatism, and typically when the pterygium has gotten to that point, it's worth getting a pterygium surgery prior to cataract surgery so that you can remove that from being a problem during cataract surgery or impacting the type of lens that you get in your eye and the measurements of the eye. So it depends on the type of pterygium it is. It's worth getting it looked at and having someone who can remove it take a look at it. But that's what I would say is first deal with the pterygium and then cataract surgery.
Okay. That's a good clarification. Thank you. This person had cataract surgery 2 years ago, and they were told that multifocal lenses were associated with halos around bright lights at night. Because of that, they chose a monofocal lens. And now, with the monofocal lens, they're experiencing strong halos at night. I didn't think that was supposed to happen. Do you have any comments on that?
Sure, yeah, happy to. So, yeah, first off, with multifocal lenses, there is that risk of halos and glare with bright lights. In a lot of cases, it is temporary, but for some, it doesn't completely go away. So it's worth considering that when thinking about the lens selection. With the standard monofocal lens, there traditionally isn't increased glare from the lens itself. Some reasons for possible glare with that lens type: occasionally some scar tissue can form behind the lens. That's called an after cataract for many. or an opacification behind the lens. And so a quick laser procedure can clear that up if that is the cause in your case. Occasionally, there can be other causes of glare. Those are numerous. That can be dry eye. That can be retinopathy. Not to scare you at all. It's probably less likely to be something serious, but it's worth getting it looked at and having a full dilated exam.
Okay. If you have one eye that is farsighted and the other is nearsighted, which lens would work best for cataracts?
So, if one eye has good distance vision and the other eye has good near vision, and you're used to that, that's called monovision, where vision's good at both. The brain has had time to adapt to having two different focal points, and it's not that uncommon, but it's also not the most common thing in the world. It sounds like that's what you have. So if you're used to that type of vision, the monofocal lens can be set so that you have good distance vision in one eye and good near vision in the other eye, so that we can essentially mimic that same type of vision after cataract surgery. So that's a good option. But that alone doesn't take really anything else off the table for you as far as lens selection. So we'd have to get good measurements, check those prescriptions. I feel like I'm being repetitive, but it's worthwhile getting it checked out and getting the measurements of the eye before deciding on a lens type.
Okay. What kind of sedation is used during surgery?
So it depends on other health comorbidities and so forth, but the most common form is moderate anesthesia. That's intravenous relaxing medication, essentially. Pain medication as well as a relaxation medication, specifically a benzodiazepine, as well as a opioid medication. This is administered with the assistance of an anesthesiologist who is monitoring vitals the whole time. This allows a patient to be relaxed and essentially to be okay with having surgery on their eyes. That's not a feeling that most people walk around with. I wouldn't be okay if I just was wide awake having cataract surgery, but we've found the right mix that allows most people to be very, very comfortable during cataract surgery without having to induce general anesthesia or intubation, which comes along with its own risks. So it's nice that we can avoid that in most cases, but in some unique situations, still general anesthesia is still needed. So patient to patient.
Okay, thank you. What are the costs of each lens and what does Medicare with supplement cover?
Great question, because that's another huge part of the decision-making process, an important one too. So I can't answer for each individual Medicare or Medicare supplement, but in most cases when it's a medically indicated cataract surgery, that cataract is impacting vision, Medicare covers most of the costs of surgery, of anesthesia, and the lens, if it's a standard lens. Once you get into the kind of that second tier of lens selection or laser assistance, there is an out-of-pocket cost. That varies depending on the lens selection you make. And also, astigmatism correction does require some out-of-pocket cost as well. While Medicare is still covering the cost of surgery, anesthesia, and the lens, there is that additional cost for the toric lens. So as far as specific prices, if you call our clinic or really any other clinic, they should be very forthcoming with that, because that is, like I said, an important part of the decision-making process.
Okay, thank you. So you had mentioned that 5% of patients do not have successful surgery. Do you know what causes the failure and what is the eventual outcome?
So that statistic, the 95% of patients have improved vision after cataract surgery. What that means is on our Snellen chart, on the eye chart, let's say they were at 20/30 before surgery, and then they're 20/30 after surgery as well. That just means that in the vast majority of those 5% of cases, that vision is still correctable with glasses or with sometimes LASIK after cataract surgery. But that number also includes those with other comorbidities, potentially with complications of cataract surgery that can sometimes cause worsened vision. That's an important point too. There are risks with any surgery, and cataract surgery does not stand apart from that. The most significant risks, like infection, is about 1 in 10,000 with cataract surgery. And that's something we monitor very closely to look for signs of. So what I would say is the vast majority of that 5% of patients who don't have improved vision, it's not that cataract surgery wasn't successful per se. The cataract was taken out, a lens implant was placed in the capsule, but that the vision on our chart wasn't measuring better than prior to surgery. And so sometimes requires a few extra steps to get there.
Okay. Since the intraocular lens is a foreign body, are there any risks for allergy to materials or rejection?
So in most cases, so acrylic is a very benign substance, and it's been tested in many cases, and it's extremely rare to have an allergy to the acrylic material or to silicone, which is another type, which some of our lenses are made out of. So in most cases, it's essentially benign, inert, and it's very rare to have an allergy to those substances. I have known of a couple patients who have allergies to acrylic materials, and in those cases, we can find alternative lens materials, alternative lenses that are made out of different materials, so we can avoid any risk of inflammation. So we have different options for those who are allergic to acrylic and silicone, our most common materials present in IOLs.
That's good to know. This is a fairly specific question, and I'll try to pronounce it. For the light adjustable lens, does it mean that you can never take hydrochlorothiazide, or only until the final adjustment is made?
Only until the final adjustment is made. So that final adjustment is called the lock-in treatment or lock-in adjustment, and that essentially locks in those macromers within the lens so that no amount of UV light in the eye and no medication certainly will alter the strength of the lens at that point.
Okay.
Great question.
If you had a small detached retina and retina hemorrhage in one eye, can you still have a cataract surgery?
Yes, you can. Yes. So often, in fact, with retinal surgery, the surgeries that are meant to repair retinal tears or retinal detachments, often when one has those surgeries, that may actually induce cataracts a little bit sooner than you may have otherwise had them through the aging process. So certainly, cataract surgery is perfectly safe in the vast majority of patients who have had these retinal pathologies, including tears or detachment.
Is it possible to correct astigmatism with light adjustable lens?
Yes, it is, up to a point. It's about 1.5 to 2 diopters of astigmatism can be corrected. So not quite as much as with other lenses, but they are partially correctable.
Is there any issue if the patient lives 3,000 feet higher than where the surgery was performed?
No, it's not thought to. In fact, that's a situation we often encounter, especially in this area. We have people, coming down from the mountains who need cataract surgery, just like anyone else, and they do fine. There's no fleshed out literature showing that alters the course of the postoperative period after cataract surgery.
Okay. Does the extended depth if field lens have fuzzy distance zones between medium and far. Second, is the far vision maximized like for golf or skiing?
It can have some fuzzy points. The best focal points are at distance and intermediate, so about arm's length. But the in-between areas, as you're talking about, aren't quite as in good a focus. But how good of focus do you need at those points? That's debatable depending on what you're doing. As long as you can have good functional vision at those points, that may still be an okay option for someone in that situation. So, but to answer your question, yes, those areas aren't quite as sharp as those true focal points.
How long should you wait after surgery before travel or going to altitude?
Well, typically, first off, we like to see our patients back the first day after surgery and about 1 week after surgery. But after that first week, you would be fine to fly.
All right. And that's the same for going to altitude?
No, as far as going to altitude or going up 3,000 feet, that's fine. It's really commercial flights, and even commercial flights are probably okay, but we recommend against it for the first week.
Okay. Can you just remove the cataract and not implant an artificial lens?
Yeah, you can. Occasionally, in complex cataract surgery, let's say trauma was induced to the eye and so forth, and it's a very dense cataract, and there were other problems with the eye, the lens is removed, and a lens implant isn't placed back in the eye. It's not thought to be stable at that point. That's pretty rare, though. Essentially, a good way to think of it, the type of lens correction that you would need, glasses correction or contact lens correction that you would need after cataract surgery, where the cataract is removed and no lens is placed in the eye. One can, if anyone remembers the type of Coke bottle glasses that people would walk around with, probably more prevalent 50 plus years ago. That's the reason they were walking around with those, is that cataracts were just removed at that point and not replaced. So yes, that's possible, but usually not ideal for most patients.
Okay. If you have had surgery to repair a macular hole, is one a candidate for laser assisted? Is that still an option?
It is. So macular holes can impact vision in different ways. So it's important to know that often with macular holes, your best possible vision may be somewhat reduced, or it may not be at all. Depends on the patient and depends on the macular hole. But laser assistance is still every bit as effective in those patients. There's no additional risks in patients who have had macular holes or the repair of those macular holes.
Is there a risk waiting too long to have surgery? Does that make surgery more difficult?
So from year to year, waiting a year or two typically is not going to cause any change in the type of surgery from our end or your surgical results. If one was to wait, let's say 10, 20 years, and that lens becomes almost white, and most people walking around with a white cataract lens, those around them can see the cataract without an eye exam. It's that dense. So for those patients who have very, very dense cataracts, that type of cataract surgery does come with additional risks. And so what I would say is in most situations, it's fine to wait a year or two. There's a subjective call on when you think your cataracts are affecting you, when they're causing glare at night, when they're impacting your best potential vision. And it's probably okay to wait until you feel like it's impacting your daily life. But as far as waiting until it gets to that point when you can't see anything, that would make it more complicated. That would make cataract surgery more complicated.
Okay. With the light adjustable, what happens after the 7 years are up? Worse vision? Another surgery?
So that was essentially part of a study that was from the slide on light adjustable lenses. that essentially was as far out as one study went, looking at and making sure that once those lenses are locked in, that they don't change shape. And so I think the longest study that was done was carried out about 10 years or so, and it showed essentially no change from change in shape of the lens itself. And so that's what that's looking at. And there can be, so it's thought that with that technologies, and it carried out to at least 7 to 10 years, that there is no change. After that, there's always a possibility of other ocular pathologies occurring. But it's thought that this lens is completely stable once it's locked in. That being said, there can always be exceptions, but that's what the literature shows.
Can you operate on both eyes at the same time?
It's possible in extenuating circumstances. The reason we do one eye at a time is our measurements and our algorithms that we use in the case of non-light adjustable lenses, the calculation is just barely off, and we want to further fine-tune that for the second eye as far as the lens strength. So that's a reason to get one eye done at a time. There's also additional risks. We don't want to induce, for instance, although it's rare, an infection in one eye, and then that's carried over to the second eye, even though a change of instruments would occur, and so forth. So there's various safety concerns about doing cataract surgery, both eyes on the same day. That being said, there are extenuating circumstances such as those who drive a long ways or have trouble getting transportation, and we're open ears to those situations. We want to help out these patients, get those cataracts taken care of, and so in some situations like that, we may do both cataracts on the same day.
This person had an eye that had a cataract that's been there since birth. They now have age-related cataracts as well. They were always told that a cataract in the eye from birth shouldn't be removed. Can you comment, please?
Sure. Yeah. So with congenital cataracts or a cataract since birth, often if it's not visually impactful, if it's not thought to cause any change or decrease in vision, then it won't be removed because the eye is still growing. Doing cataract surgery in a newly born patient or a newly born or someone who's very young can be a little bit more risky. And often in those cases, the lens is removed, and that would be another situation where a lens implant isn't placed in the eye because the eye is not done growing. So those can be reasons why the cataract wasn't removed. If it's thought to be impacting vision whatsoever, once again, that cataract is removed. But later in life, when it comes to age-related cataracts, and those that have congenital cataracts as well, essentially opacities in that clear lens have occurred at various layers of the cataract. One layer is where cataracts from birth occur, and the rest of the cataract becomes opacified from age-related changes. In most cases, it doesn't really impact the outcomes of cataract surgery. It can be just as successful. It depends on what type of congenital cataract you have as well. So it's worth getting it looked at. But when it comes to age-related cataracts, we know what to do with them. And when it comes to congenital cataracts, that can be taken care of too.
Okay. If you have glaucoma, does that affect cataract surgery decisions?
In some minor ways, and some major ways. So it depends on the severity of glaucoma. If it's currently controlled, pressure in the eye is controlled and everything, then having cataract surgery alone can have essentially the same outcomes as those without glaucoma. In those that have severe glaucoma and also cataracts, then often we want to get you in the hands of a glaucoma expert who can sometimes carry out a glaucoma surgery along with the cataract surgery, essentially a 2-for-1, where both pathologies can be dealt with.
Can this surgery be performed on a diagnosis on granulomatosis, Wegener's disease?
Yes, it can. We occasionally make some modifications to the preoperative or postoperative care if you have a form of GPA, as it's called now, which is a vasculitis that affects the eye. So we have to make special accommodations when there's changes to the eye because of this disease. But in the vast majority of cases, cataract surgery can be conducted, and we still want to get rid of that cataract to get it replaced with a lens implant. But as far as specific changes, it depends on the severity of the disease and how it affects the eye.
Do you use the Aura system refractive analysis during the operation?
We occasionally do. Essentially, when we feel like, I'm speaking for myself as well as the other surgeons that practice, when we feel that the measurements of the eye don't seem to be adding up, which is rare, and that's where the Aura can come in handy. What the Aura is essentially within surgery, with dilation, and with a better view of the entire eye. It takes additional measurements, and you can make adjustments to the lens strength based on those measurements. So you essentially bring 2 lens implants with you to the surgery room as the surgeon, and you can essentially pick out which one works best based on this intra-surgery modification and measurements of the eye. So we occasionally use it, but it's rare in my practice.
We have time for a couple more questions. We want to remind the audience we may not get to all questions tonight, but let me get through these 2 or 3. This person is cross-eyed in one eye. Does that affect cataract surgery?
So it can. And those who have what we call strabismus, some people call cross-eye, but essentially where the 2 eyes aren't aligning completely, it can impact not the surgery itself. Typically, the surgery itself will go through just fine with no additional rate of risks for those who have strabismus. But as far as outcomes after vision, occasionally if you currently wear prism in your glasses to bring those 2 eyes together, it can cause a change in the amount of prism that you need. Maybe induces more strabismus or decreases the strabismus. So it depends patient to patient.
Okay. This person would also like to get a vitrectomy. Is it better to get that before or after cataract surgery, or can it all be done at the same time?
So a vitrectomy, it depends on what the vitrectomy is for, first of all. A vitrectomy is a retinal surgery where the jelly inside the eye is removed. The most common reason for it is for those who have excess of floaters in their vision. And it's done by a retinal surgeon. And this surgery aims to essentially reduce those floaters or eliminate them. If that's the reason for it, I would actually suggest getting the vitrectomy prior to cataract surgery. Not that I ever want to make a business out of dissuading people from having cataract surgery, because it is a great thing, but sometimes those floaters are what are so obtrusive in your vision, and after those get cleared out of the way, that cataract doesn't seem so bad. So in many patients, vitrectomy first may be the best option, but it really depends on the severity of the cataract as well.
And then back to insurance.
Sure.
You mentioned Medicare, but what about private insurance? Does it cover the enhanced lens?
No, private insurance, essentially all private insurers, they follow suit with Medicare as far as what they cover. And so essentially with astigmatism correction packages or premium lens options like multifocal, light adjustable lens, while they should still pay for the surgery, anesthesia, and some additional costs in the post-operative period, certainly, they won't cover most premium lens types, or any premium lens types, I should say, or laser assistance with the cataract surgery.
Okay, thank you.
Yeah, great questions.